problem that we see in a routine pediatric practice. And I think, unfortunately, to diagnose a cause of cough is very difficult. Managing cough is further difficult because no cough syrups ever work. The coughs get better either by themselves or by just accident. And I think barring a specific cause that we may be able to pick it up, the problem of cough really is very harassing. And I think when the problem of discussion is the recurrent cough, that really is very depressing. I'll talk about the very basics of how I approach in my office practice a problem of recurrent cough. The very fact that the cough is recurrent means we have not been able to pick up a correct diagnosis, otherwise it would not recur. And with this kind of an introduction, let me take you through some first basics. Can I have the next slide, please? Well, I think we need to be very sure that recurrence is not an accident. I'm sure if somebody falls once, it's an accident. If he falls second time, it's a bad luck. If he falls third time, there has to be a cause. You put this to anything. You have a seizure in an 8-year-old, maybe first episode of an epilepsy. Let's hope he doesn't do it again. Does it second and third time, it becomes recurrent. The management is required. So anybody who coughs therefore recurrently is really not an accident, but we need to have a proper evaluation. And I think the most important part of the clinical evaluation is to really go systematically and find out what's the anatomy of the disease, then what's the pathology of the disease, and finally what's the etiology of the disease. Unless I know these three things in sequence, unless I know where is the disease coming from, that's the anatomy of the disease, I cannot even consider what's the type of disease, that's pathology. And unless I know anatomy and pathology, I cannot even guess etiology, because etiology is a total guesswork based on anatomy and pathology. And I think to that extent, let us every time look at a cough from the point of view of anatomy. And this morning we heard Mahesh talking about how to pick up anatomy by just the noise. So there are ways of picking up an anatomy of a disease by a mere clinical evaluation. Once we know anatomy, we talk about pathology, and we all learned in pathology that it may be inflammation, infection, tumor, benign, malignant, all those terms that we learned in earlier years in our undergraduate days are very, very pertinent, because that is based on a clinical evaluation of the origin, duration, and progress. That we know that something that is inflammatory may have some clinical clues of inflammation. And unless we know anatomy and pathology, we cannot really even consider etiology. And even considering etiology, I think if we formulate the basic rules, for example, what happens suddenly in clinical medicine is trauma or mechanical or allergy or vascular or neurogenic. Infections don't happen suddenly. Therefore, origin, duration, progress. Each time we have been taught this in undergraduate days. And if we do not continue from there as a postgraduate or an expert, you are missing a great link. So it's so vital to see what's the origin. And then, of course, the progress. For example, what happens suddenly in clinical medicine, as I said, is trauma or mechanical factor like a foreign body, but that does not disappear suddenly. But what happens suddenly and also disappears suddenly may be allergy, or maybe vascular or a neurogenic. Seizure comes, disappears. And further, what happens suddenly, disappears suddenly, and recurs often may again be not trauma, mechanical, often then allergy. So how easy it is if we just assess the origin, duration, progress, and that's the way we even guess etiology. And I think if we keep these basics in mind, then we know that we are likely to evaluate the cough properly. I think trial with cough remedies is irrational simply because I'm sure all of us know that there is no single cough syrup that you have experienced that works. In fact, no cough syrups work. And even then the parents expect you to give a cough syrup. We will discuss at the end what is the ethical issues of writing a cough syrup or a rational approach to writing cough syrup. But it's rational for parents to expect a cough syrup because you're coughing. And I think we need to therefore realize that cough syrups are of very minimal use. Whenever we try some cough syrup rationally, we also know rationally that they may not work. So there are situations where we may prescribe in the hope of its working, but there are many others where we know that they will not work. Therefore, just a trial with cough remedies is very irrational if we have never evaluated this. I think antibiotics without justification is useless. And I think time and again we have said that to write an antibiotic, you should precede a prescription of an antibiotic with a label of at least a bacterial infection. If possible, even say gram-positive bacterial infection. If possible, say gram-positive community-acquired infection. And I think then deducing the antibiotic is a very, very standard procedure. But the fault is most of the time we find the name of the patient and the name of the drugs. In between, everything is missing. Therefore, I think my plea is in clinical medicine, we have to really commit a diagnosis. And you know, in all institution, hospitalized patients, there are two columns of diagnosis, provisional diagnosis and final diagnosis. It gives you a courage to know that if there are two different columns, provisional diagnosis may be often wrong and the final diagnosis something different. I think the science has accepted that there is to be a provisional diagnosis and final diagnosis may vary. But it presumes that there is a provisional diagnosis to begin with. And I think let's attempt in a child of a recurrent cough, a provisional diagnosis. It may be a wrong diagnosis, doesn't matter. When you commit a diagnosis, you are likely to know your mistake. If you never commit a diagnosis, you are never wrong, but unfortunately, you are never right as well. And I think, therefore, just this kind of a justification is not right. I'm sure Dr. Soumya accepts that hypothetical anti-TB treatment is very unacceptable. Don't say that TB is common in our country. There are far many more respiratory conditions commoner than TB in our country. And I think any treatment which is prolonged, any treatment which has a lot of repercussion on what happens subsequently, I think it's very important that we have a reasonable, at least logical reasons for starting such a treatment. And I again would present a strong plea that every time you write a long-term treatment, maybe anti-epileptic, maybe anti-asthmatic, maybe anti-TB, it has to be preceded by a logical reasoning for arriving at a diagnosis. If I give you a 5-day course of some treatment, even without a great basis of Therefore, I personally never accept a hypothetical anti-TB treatment. We will just again go through a very basic facts that a significant severe cough is an airway disease. And this morning we did discuss some of the issues, that anatomy is an airway. And therefore, again, if I make some statements out of proportion, I'm sure there are exceptions to these statements. But still the rule holds. To me, anybody who has a significant or a severe cough has an airway disease, and an X-ray test is a useless investigation. In fact, more often you ask for a chest X-ray because he's coughing. And if he's coughing badly, you ask for a chest X-ray definitely. And I feel it gives you a very little or probably none the information, because it often would pick up either a parenchyma or a pleural disease or a mediastinal disease. Well, exceptions would always be there, and we saw how a ball valve obstruction of a obstructive emphysema in a foreign body was picked up when a child was badly coughing. I understand there would be some such thing, or a mediastinal tumor with a pressure causing a cough would be picked up on a chest X-ray. But if you see 100 patients in your office practice coughing badly, very likely there may be one at the most or none who has a mediastinal tumor or a foreign body, and that you can easily spot out, because foreign body is an acute onset cough in a healthy normal child at a particular age that we discussed. Therefore, it's not that when he's coughing badly you never ask for a chest X-ray, but very likely you will not get anything better on a chest x-ray. Nature of cough localizes anatomy to upper or lower, and we saw how the noise, and one of the noises that are coming out of a respiratory pathology is also a cough producing noise and a type of cough. And I'm sure we learned this as an undergraduate, that you have a different kinds of cough, almost depicting a different sites of a disease. And I think we need to give an allowance to all such simple issues to go by. Fever denotes infection. The point I'm making is that no fever is almost no infection. Exception, yes, a chronic low-grade infection. But if you have an acute onset issue, I think if you have no fever, almost never an infection. So forget giving an antibiotic to a child of cough who has no fever. And fever may not mean a bacterial infection, that we know very well. But how often would you have written an antibiotic as a trial to a child who has a cough when he has no fever at all? It is very, very unlikely to be an infection. And then, of course, non-infective causes present generally without fever. You have, again, exception there. You may have a malignancy, for example, with fever. But those are not the common office conditions. And again, therefore, going back by common prevalence, I think these rules stand true. And then, I think it's a good idea to differentiate persistent from a recurrent cough. For example, an asthmatic cough may be a recurrent episodic nocturnal cough, but the disease is persistent. For example, a child of tuberculosis has a recurrent fever maybe, or a fever off and on, but the disease is not off and on. So there are diseases where they get better completely, recur again, whereas there are diseases where the disease is persistent, but the cough may be recurrent. And I think we need to therefore even address the issue whether I'm dealing with really a recurrent or it's just a recurrent manifestation of a persistent disease. And I think once we go beyond that basics, the next slide please, let's talk about the case scenarios and see where we fit in what we said, basically how we approach the anatomy, pathology and the etiology of a recurrent cough. This is a 2-year-old who has a recurrent cough and fever for a year. Now, onset of fever followed by cold and cough. Fever remits within 3 days, the cough worsens. Now what happens here? You have fever, so very likely infection. So we'll start with applying the rule. Fever of an acute onset symptom is an infection. So this is an infection. It's recurrent, so it's a recurrent infection. And how does it start? Starts with fever, cold cough, but by the time the fever disappears, the cough is even getting worse. I'm sure this is not an uncommon scenario at all. And what happens to an ill-informed pediatrician? He starts antibiotic right on day 1. At the end of 3 days, the fever disappears, but the cough worsens, so he changes an antibiotic. Now, very fact that this is infection and an infection quickly remitting, but the cough worsening indicates that the etiology of or a pathogenesis of fever and a pathogenesis of cough seems to be probably different. That one got better quickly and the other even got worse. So obviously the pathogenesis of this fever and this cough looks different, but then both are related. We heard Nagabhushan telling us that don't diagnose 2 diseases at one time. So even if the pathogenesis of fever and the pathogenesis of cough is different, the etiology must be same. What is then this etiology? This is typically a viral infection which induces a response in an airway. The infection disappears quickly without even an antibiotic, but the cough might even worsen. And I think this is typically a situation of a post-viral infection cough, and this may recur off and on. What is very important, that any time there is a recurrent fever, that means there is a recurrent infection, I think just address very common basic issues. In spite of a child having recurrent problem, has the child deteriorated in health? If not, this is almost always a recurrent viral infection. What is the peculiarity of viral infection? They lose a kilo maybe during an acute illness, and they make up that kilo in a short time thereafter. Therefore, if you have a recurrent viral infection like this, all that you need to do is just to reassure the parents. And I'm sure this is a difficult cough to treat. And you may start giving a reasonable idea to the parents. For example, I always tell the parents of my patients that if you have had a fracture, then you sit in a plaster for next 2-3 months and never ask an orthopedic surgeon whether there could be an imported plaster that can reduce the duration of disability. Everybody accepts that it takes long time for a bone to remodel. How can you expect each time the cough to get better? But this is the cough where you may sound them to say, don't worry at all. So first they're reassured, and add to say, this is going to take some time. I think it's only when we tell them ahead of time that it's going to mean some more time and you will have to be patient. I think partly they're ready. Otherwise, they expect you to do a miraculous recovery of even a cough. Tell them that the fever has gone, so infection has gone. But the effect of that infection continues, and that effect will take its own course. We won't discuss a great deal about what kind of treatment would you give, and I'm sure this is a condition where the treatment is usually miserable failure. Therefore, each one of us must try to achieve your own experience to say what works. Somebody might say only time works, he's right. Somebody say prayers work, maybe he's right. But most of the drugs don't work. So what do I do in my practice? When I do this, I reassure them to say there's no worry, he's going to outgrow this. That is certain. I don't need any investigation. But then the parents are not interested in your diagnostic label or an ability as a wise clinician. They want a relief to their patients. Therefore, I tell them that I can't cure your child's cough, but what I will try is to give relief or comfort to your coughing child. Cough will not get better, but I will make a child comfortable. So what do? I have a child still coughing, but he's comfortably coughing, if you like. And that's the best I can achieve. And the cough will take its own course. If you don't explain to them this, they would say your treatment has failed, the cough continues. I've already said my treatment is going to fail. Time will act. But all the same, you can't have that child cough the whole night and the parents are also awake the whole night. You owe some relief to that. And I feel even when there are coughs of this kind, say wheezy cough, typically wheeze-associated lower respiratory viral infection, I think bronchodilators, inhaled drugs, etc. are a big failure. To me, what may, if at all, work is maybe a cough suppressant with an antihistaminic given a single dose at bedtime. Everybody sleeps, which means you sleep and cough. Parents also sleep, don't hear the cough. And next morning they say, night was not bad, but doctor, still he coughs through the day. And is he not active, playful? Yes, he is. But now we are relieved, the nights are all right. I think in medicine, when you can't cure, you have to give them some relief. Relief by some logical, rational approach. And I think that is all that we can do. And I think if you keep this in mind, Nagabhushan talked about the communication. I think we need to communicate very clearly that this is what the situation is. Otherwise, they expect a miraculous improvement. The next one, please. This was a child who has a 2-year-old, similar. He also gets recurrent cough and fever for a year. Onset with high fever, nasal discharge, cough, better with antibiotics. Now he is getting better both, fever, cold, cough, nasal discharge, everything gets better simultaneously in a short time. Unlike the first child, who in fact got worsened on his cough and coughed for the next 2 weeks, the parents are very happy that your drug acts every time. The first child, the parents are worried that fever has gone, but the cough hasn't gone. They're unhappy about your treatment and also unhappy because it's recurrent. Here the parents are very happy. And each time you give a different antibiotic because you should sound wiser and different each time. And therefore, every time, fine. They're never normal in between. There's a mouth breathing, there's a dribbling of saliva, there's snoring, the adenoid faces. What I'm trying to say is that if this is clearly a recurrent bacterial infection, then as pediatricians we know that if you have a urinary tract infection, even a first episode, you are bound to demonstrate whether there is any background cause, lest it may recur, and if it recurs, it may damage the kidneys. And I'm sure every one of us knows that very well. There was time when we were training that they said, it's all right if you had a second episode in a female child, maybe third. Today we know that first episode of UTI is a warning. But we don't take it seriously if there are nth episode of upper respiratory bacterial infections. We do take care of a recurrent pneumonias. We do take care of a second episode of meningitis and UTI. But when it is a recurrent upper respiratory infection, we say this does happen. It does not happen. A recurrent bacterial infection anywhere in the body, in a short spell of time, demands that there is a background cause. Recurrent viral infections, you need not investigate at all. So it's vital for us to differentiate bacterial from viral. And if it's a recurrent bacterial, there has to be a background cause. If you require to give a second time an antibiotic in a month's interval to a similar disease coming up with fever, cold, cough, while you write an antibiotic, start planning investigations. And what investigation? Simple. The background cause is either anatomical or functional and very rarely immunological. Immunological is not an issue. And I think in your early life you don't see immunological diseases at all because they are getting worse and they go to somebody senior. And as you get senior, you understand that they are so rare that you need not start thinking immunologically. Even then the parents keep on asking you, do you think his immunity is poor? And I think, what does that mean to a medical person? How do you know that the immunity of the child is poor or not poor, good, bad? I think I explain the parents in a simple way. I tell them that your child is falling recurrently sick. So you are worried whether his immunity is low. But how do I know whether his immunity is low? So I tell them that if I push you, you fall down. If I push you 10 times, you fall down 10 times. What does it mean? It means I am stronger than you. It doesn't mean you are weak. I am stronger than you. How do I know whether you are strong or weak? I know by only one method, how quickly you get up. So I pushed you 10 times, you got up 10 times quickly. That means you are also strong. But I am stronger. Therefore, the treatment is stop the stronger person from coming near you, if possible. There's nothing weakness there. And I think the parents understand this kind of a communication. That they do know that if you fall down but you are strong, you may quickly get up. Otherwise, you will take long time to get up or you may not get up. And I think if the virus is stronger than your 2-year-old child, every time the virus comes, he falls down. But does he not get up quickly? 2 days fever disappears. That means he is strong. Can you stop that virus? We have learned the risk factors. Bottle feeding, crowding, daycare, this, that. Take care of it to an extent possible. And over time, he will develop a tolerance to that nonsense. And I think that's the way. This is definitely a recurrent bacterial infection. Most common cause anatomical problems. So maybe enlarged adenoids, sinuses. Okay, and rarely functional, like maybe a ciliary dyskinesia, maybe a cystic fibrosis, all rare. And immunological, extremely rare. When I asked my postgraduate, what's the commonest immune deficiency you have seen in this country? Before HIV came in, they would say combined T and B cell defect. I think you combine everybody's wisdom, there is not one case seen. What is combined T and B cell? The commonest immune deficiency is a severe malnutrition. Other common immune deficiencies are chronic organ failures. A chronic renal failure is an immune deficient child. A chronic hepatic failure is an immune deficient child. And therefore, when you talk about immunity, you almost thought whether he is born with something terrible. I think it's extremely rare. Therefore, the corollary is those so-called immune enhancing agents in the market are of no use whatsoever because none of us are born with that kind of a deficiency. And if you have deficiency, none of them ever work. And I think, therefore, there is nothing wrong with immunity. There's something wrong with the child anatomically. And as in this child, it was adenoids. The next one, please. This was an 8-year-old child who has recurrent cough and fever for 3 years. Now, this is an elder child. The first two are typically a viral infection, a bacterial infection. Fever meant infection, so we are treating infection. and the background. This child also has that. Now he has a high fever, he has also similar thing. Now he is a bigger child, so by then he has developed already a sinuses, and therefore he may have simply a sinusitis. I'm sure we are all getting now familiar with a sinusitis as not uncommon condition at all. Very difficult to diagnose. The Westerners diagnose by CT scan. We don't have CT scan even for an indicated issues. Therefore, we need to make a guesswork many times. We are told that X-ray is not very good to diagnose sinusitis. Well, if X-ray shows it, it's there. If X-ray doesn't show it, may not be still ruled out. Ultrasound may be sitting in between a plain chest X-ray and a CT, but I still feel 10% of the times you should be right, which means you are allowed 10% to be wrong. And that's a good judgment. And I feel that between a viral and bacterial infection, one could be 90% right if we apply just few clinical markers. To me, viral infection mostly start with a moderate or high fever. And by day 3, day 4, the fever generally subsides. There are always exceptions. Once you master this rule, you start picking up exceptions. But unfortunately, exceptions are very impressive. And we pick them up first and then realize that the rule is totally different. So when you teach your child how to cross a road, you tell him when it's green, you should cross the road. Once he masters that lesson, the next lesson is, son, if the signals are not working, how will you cross the road? If he says only when it becomes green, then he will not cross the road. But that is a second lesson after he has mastered the first. And of course, the super specialist can even cross the road when it is red. Okay, that's a different story. What I'm trying to say is that let's master the rules and follow them. Once you follow the rules, you say, oh, it works 9 out of 10 times, but once it doesn't work, then you start looking which is this one where it doesn't work. That's where you are coming to learn exceptions. So to me, viral infection starts as a moderate or high fever, gets better by 3-4 days. Most important is every time you give a paracetamol, fever comes down, the fellow is active. He is not sick. So interfebrile period is near normal. And I think that's almost definitely a viral infection. Add one more, that viral infections are generalized infection. Bacterials are localized. What is viral generalized infection? Congested eyes, running nose, congested throat, coughing badly, whole respiratory tract. If you like, even diarrhea, vomiting, GI. How much generalized? Another child in the family also suffering, generalized. Everybody in the community suffering, generalized. What is localized bacterial? Tonsillitis don't run noses. Pneumonias don't have congested throat. And they don't have, oh, everybody in my family has pneumonia. No. Then that's viral pneumonia. Okay, so how easy? To a scientist, it's not perfect. But which scientist is perfect? And therefore, we don't want to be a perfect scientist. We want to be reasonably right mostly. And I think therefore for me, viral and bacterial are very, very easy to differentiate. And then Palni Raman has taught us how a peripheral smear can differentiate viral from bacterial. Okay, and I'm sure last time also he gave a talk and he makes a point that if you show bandemia on a peripheral smear and a thrombocytosis, then it's almost always bacterial. And if you show vacuoles, which is rare to see, you're also bacterial. Those toxic granules are also viral. And therefore, bandemia, thrombocytosis, if you are lucky, vacuoles, makes it a bacterial infection under a clinical evaluation. If you have a recurrent bacterial infection, start investigating the cause. I think it becomes very, very easy, and this was obviously the cause. The next one, please. And then the 10-year-old child with recurrent cough and fever, again, temporary improvement, worsening episodes. Again, a bigger child with a repeated bacterial infection, but he had some and then I know that he had an IgA deficiency. All that I want to stress is, all these patients have had fever, so they have infection. It's not difficult to differentiate viral from bacterial. If it's recurrent viral, forget. If it's recurrent bacterial, always attempt. If it's a younger infant, it's adenoids. A bigger child, maybe sinusitis. If it's a low respiratory younger infant, it's something terrible, cystic fibrosis or maybe immune deficiency. If it's an elder child with a recurrent lower respiratory infection, then I think it's very likely again something serious underlying. What have we learned? Recurrent lower respiratory infections are always something serious. And a recurrent upper respiratory infections are even bacterial. Probably the causes are not difficult to make out and are curable. The next one, please. And then this is a child who has a recurrent cough but no fever. The moment he has no fever, I say, oh, you probably have no infection. And then he has an episodic nocturnal cough, etc. Typical story. Doctor, whole night he coughs. What about day? Oh, you'll be surprised, the whole day he never coughs. Okay. And I'm surprised that you do a MAN2 test. You think tuberculosis comes up after the sunset and disappears after sunrise? What is wrong? There is no question of doing a MAN2 test. I'm sure that Dr. Soumya will agree with me that doing a MAN2 test without even a consideration of a probability is a crime in India. Because MAN2 comes positive and the fellow has no even clinical probability of TB. Then you pursue MAN2 tests. And I think tuberculin test is not a routine test at all. Before you do a tuberculin test, put down the reasons why it could be. Therefore, the plea is that laboratory tests are useful, no doubt, but they have to be done only if a clinician has a strong reason to suspect that probable disease. And you can't investigate 10 diseases and pick up one. And I think this obviously is an asthma, and we know we are going to have a lecture on asthma as well. And the next one, please. And this is a child, a 2-year-old, recurrent cough, failure to thrive, breathlessness off and on. He has occasional fever, not really much. But his major issue is this, but he's failing to thrive. He's also breathless. Obviously, even if he didn't have any obvious clinical signs, he may have a failure to thrive. That means a progressive disorder. A progressive disorder which is not infective. And therefore, again, some congenital malformation like say simply a left to right shunt, and he comes to with recurrent cough. But there are enough clues, and even if he did not have, say, a murmur, you could have ordered some investigation to pick up a cardiac cause. Therefore, I think having said these kinds of case scenarios, I think if we follow a simple algorithm, 99% you would be right in denoting what the cause is. It doesn't mean that you can get rid of that cough, but at least you know how to progress. And next one summarizes all that I said so far. That I start with recurrent cough and say, is it febrile or not febrile? Now, no fever is occasional fever. I think we use the word occasional as in when we are not sure whether it is there or not. I'm sure during your training days, you did write in your notes, throat mildly congested. Now, whose throat is not congested? And that too mildly is accepted. Then you said occasional crepitations left face. I always ask my residents which occasion was that, because I did not find. And so that occasional fever, I think, is to me no fever. And every time the parent must have said, oh, he appears a little warm. Well, little warm is occasional, no fever to me for this analysis. And if you find it's a viral infection, and we already said viral is a generalized disease, do nothing. Again, the pointer is that as viral infections start early at about a year of age or so, when they start getting into the community, and then as they grow up, there's no reason why they should have a viral infection. And therefore we know that viral infections start around 6 months to a year and die out by 3-4 years. And if that is what is happening, then you call certainly a natural progress of a recurrent viral infections and a cough. If it's bacterial, then you have to be very, very sure that you need to investigate. As I said, that if it's upper, then you may have a recurrent adenoiditis, tonsillitis, sinusitis, etc. A word about tonsillitis. Larger the tonsil, not necessarily it's tonsillitis. And I'm sure you need to have an inflamed tonsil to diagnose acute tonsillitis, but a chronic tonsillitis with acute exacerbation are even diagnosed by a small shrunken tonsils. But the best way is to use a spatula and almost press on that tonsil, and you might find a bead of pus coming on that tonsil. And I feel that's a chronic tonsillitis, which is not a large tonsil, which is not an angry red tonsil, which is not a tonsil which is a difficulty in swallowing, painful swallowing, but it is that tonsil which is small, shrunken, but still holding on a beads of pus. And I think that's the tonsil that needs to be removed. and that's a recurrent tonsillitis. Of course, if you have a low respiratory, then you are on a more serious problem. But on the other hand, if you have no fever at all, then generally referred to as a hyperreactive airway. How do I explain to the parents what is hyperreactive airway? I tell them that hyperreactive airway is a short-tempered airway. Like some people are short-tempered. So immediately the wife looks at the father and says, he's referring to you. That's why our child also has short-tempered airway. Now what is short-tempered? No definition of short-temper, but the definition loosely is that if I say something to you, 9 out of 10 don't get angry, you flare up, that means you are short-tempered. So I said your child's respiratory tract is short-tempered. It flares up with little virus going in, little dust going in. Everybody is taking virus and a dust antigen, mite antigen, but everybody doesn't flare up. Your child flares up, short-tempered. It's often genetic. And therefore, this is a short-tempered respiratory tract. What do you do to a short-tempered person? If my boss is short-tempered, then I talk to him very softly. I knock the door very softly and I see whether he's shouting or he says, please come in. Then I go and very humbly speak. That means a management of short-tempered person is not with the person, with the rest of the people. They have to behave well, otherwise he will flare up. And if you behave well, then the short-tempered person also behaves well. And people say, oh, you thought you were short-tempered? With me he is never, because you are behaving better. That's why he is not. So short-tempered airways is managed by others. What is others? Environment, all that we have said, trigger factors. They are important. You are not changing the temper of the fellow. You are changing the environment conducive for a short-tempered fellow not to flare up. That's my asthma, hyperreactive airway. Now why is short-tempered? For various reasons. And most of the short-tempered people in a young age start cooling down thereafter. And when you see an old person, his contemporaries say, oh, as a young man he was very short-tempered and now he is cooled. Many of these fellows also cool down over time. So tell the parent this temper will cool down. But we need sometimes an intervention. But who is to intervene in whom? All of us. Not that child. Don't tell him, come on, don't cough. Don't get angry. He's bound to get angry. That's his personality. You need to change. That's hyperreactive airway. Now some are atopic, allergic, and some are non-atopic. Okay. If I'm in a bad mood, I'm not a short-tempered person, but I've had a bad day. Okay. I'm tired. I'm not well. Now the last patient comes without appointment. I flare up with him. And he says, I've never seen the doctor so short-tempered. I think today there's something wrong. That means I'm not atopic. I don't do it every now and then. But I have some other factors. And that made me temporarily as if hyperreactive. These are the fellows who are like that. You have a premature child, he has got a smaller airways. And over time, he will stop showing his responsiveness. You have a small baby with an aspiration, neonatal lung damage. He will keep on doing it for a while, and after a year or two he will cool down. Therefore, these are all short-tempered airways, and I think if you look at them, many will get better, and to make them get better, you will have to change the environment, and of course then, not every time you have to speak softly. Sometimes your short-tempered boss, even your presence might blow his temper, because he doesn't like to see you also. Now how soft you could be. Therefore, then you need a mediator. So when my boss is short-tempered, he doesn't like to see my face also, but I have to go and report to him something, then I take with me somebody who is a mediator. And his presence cools him down a little. That's our inhaled corticosteroids, etc. They don't cure anyone, but they temporarily say, come on, now don't get flared up for a while. That's the treatment. So once you know the philosophy and tell the parents, communicate it like this, I think it becomes easy for them to understand. I'll just end up by saying, what have you told the parents all this time? You have said, I can't do anything for your cough. But you have said it in a manner that they thought you knew everything how to deal with that cough. I think that's the way to really treat cough. This is not easy, but I've just given you an idea of how to diagnose the probable condition behind recurrent cough, where you need investigation, where you need intervention. Where you are bound to fail even then succeed because the child's life is not in danger, and there you have to succeed by communication. I think a doctor has to be a good lawyer. He can even defend his failures in a manner that the judge feels he has won. And I think that's the way we go by. Thank you very much for your patience. Perfectly right. I think what he says is right. Probably they are just accidents. When accidents start happening too frequently, one starts worrying. That's the only thing. And therefore, we need to explain the parent that this cannot be really prevented. And I think it's our confidence in telling the parents, and it's our own conviction to tell the parents about our diagnosis. And many times the parents have asked me one last question. Doctor, are you very sure about what you said? Because they're still not convinced whether you're making a mistake. And I think that's a tricky question to answer. My answer always has been, I'm sure of only one thing, that this is a very honest opinion. I'm not sure whether this is right. So they look at you and say, oh, you also are not sure whether you are right. But then I add another sentence, if you are honest, mostly you are right. So I think this convinces the parent that within the limits of science and human understanding, you are giving your opinion. And I think be firm in your opinion, put it on paper. I think if you put on paper, it's very convincing that you are committing in writing, you must be right. And I think committing on paper is a prerequisite of every clinician. Every X-ray report comes with a big commitment. Even if they say query Heilers, it's a commitment. It's on either side. And I suppose that we need to commit.
You told that sometimes once infected, you have to wash and get out the first 2 diagnosis.
Pardon?
Chronic tonsillitis.
Chronic tonsillitis, yes. The reason I made a specific mention about chronic tonsillitis is, as a pediatrician, you are often asked whether the ENT man has suggested to knock out the tonsils and whether you should okay that. And I feel, therefore, that if I have definite episodes of a recurrent tonsillitis, in general public, everything is called tonsils. In fact, you must have heard in Mumbai, parents come and say, my child has tonsils. I said, that means he is normal, isn't it? They ask, no, do you think it's a liver? Of course, there is a liver. So what they mean is that that's a fault. I feel, therefore, that chronic tonsillitis is important to diagnose for a tonsillectomy. And chronic tonsillitis is not an easy diagnosis. But once I learned from my ENT colleague some years ago that you try to almost pinch that tonsil, not every time I'm able to pick up that bead of pus. Because after all, what we do is less often than what ENT people look at. But I think it's a good idea to look at that to decide about this. Now, ENT is all together. So you have never a tonsillitis as an isolated problem, but in bigger children it is. In younger children it's all adenoids, and one wonders as a parent that you have a recurrent ear problem and you have been advised to knock out adenoids. So I suppose that is where we lie as far as the chronic shrunken tonsils with beads of pus is concerned. Every time there's an infection, the body tries to heal that infection. In the process, if you agree that a chronic infection, the lung may end up with a fibrosis, I think there is always a similar shrinkage of a tonsil, and even then it's an abnormal tonsil.
Probably with the tonsillar nodes.
Yes, yes, absolutely right, that if you have a tonsillar nodes, then you... I can't hear you, sir. What is it?
The role of antibiotic in subclinical infection.
To me, infection is present or not present. Okay. And what is subclinical? That means clinician will not understand. What are you asking me? Isn't it? Diagnosis of subclinical infection is not a clinician job. Hyper anxious child. I think Nagbhushan gave us some idea that first thing, whenever the parents are not satisfied, you don't get upset and don't be rude. Okay, sympathize with them that their child is still suffering in spite of your doing best. Okay, that's a good start to begin with. If you say, what do you mean? Go anywhere in the world, this cannot be treated any better way, then I think you are asking him some trouble. Say that I understand with you and I sympathize with you. Okay, so he thinks you are halfway at least better with him. That really cools him down. And then say that, bear with me, I can assure you this will not really endanger the life of a child or a chronic problem to come up, but be patient. Of course, he would say, how long to be patient? Okay. And I think therefore say that this is a limitation of science and then partly a limitation of human being as I stand. I think when you agree to this, most of them accept what you are doing. All that they want is to know how confident you are. And I think, remember, if you are confident, you don't get angry. If you are diffident, you get angry. If you are confident and parents ask you 10 funny questions, you are very cool to answer. When you are diffident, you don't want the next question. And finally, if you say, look, I am a doctor, you don't understand, don't ask me anything. If you like, take this treatment, otherwise go. That is diffidence. And I feel it's not easy to say what exactly you do, but I would say that if anything is beyond your immediate control, be sympathetic, be patient. Accept to say these are limitations. Add a word, limitations of science. He has not learned science, so what does he know? Limitation. Then say human beings also have limitation, but I can assure you that your life is not in danger and you will be all right. Be patient. And I think he will be like that. So I feel tackling the parents has to be with confidence and with all humility. Okay. And as again Nagbhushan said, send it to Mahesh Babu. At least let the parents know that he, being a pediatric pulmonologist of good training, also cannot get rid of that cough. That means your image has gone up. Yeah, thank you.